So hello again. Now you have your coffee in you. You have to listen for longer this time. So I'm Susan Phillips. I'm from Queen's University. This is what it looked like the day or two before I left. That's Queen's University. It was a great pleasure to arrive here, I have to say. Okay, this is correct. I'm talking about FutureGEN, and there were three leads on this project. Ricardo Rodriguez, who was in Austria at the time and who's an economist. He's now in Portugal. Stefan Forsch, who's a social scientist and based at the Karolinska, and myself, and I'm from medicine and public health. But we had a whole team of people, as I think did all of the projects, and this is the sort of official pictures. We've aged a lot since these pictures were taken. So let me sort of give you the background about the project. Women outlive men, but they live a greater proportion of their lives in poor health. And in developed countries, older women are more likely than men to use formal care services and to be informal caregivers. So we aimed to understand gender differences among older adults in both health and caregiving and receiving, and how these changed over time and into the future. That's the FutureGEN part of the title. And how they changed with changing social contexts and changing life choices. And we also had a cross-cutting theme, which is where I came in. We wanted to ask whether gender bias is embedded in the health measures that are used to look at these evolving trends in health and care of older adults, and particularly in survey data. And we did use a lot of survey data. So in summary, this is our website, and that little line is what we did. So GenderNet Plus created an opportunity. Oh, hang on. Oh, I can stay there. It created a real opportunity for the three lead researchers, not leading, lead, from economics, social sciences, and medicine, who'd never worked before together. And it gave us the chance to develop new ways of thinking about old problems. And I think we forged a dynamic and a really invigorating team of about 14 researchers. They ranged in age, this is biologic age, from student to near retirement, that's me, and across 5 countries. And we also had a sounding board. I should say that Janet Jull is here somewhere. I can't see, but she's out there. She is, also from our project. And that's her. And Janet said right from the start that we have to have a sounding board. We have to have a group of, in a sense, advisors from policy organizations who will kind of keep us honest and make sure that what we do is useful. And so we had this sounding board of people from key international organizations, and we met with them on occasion, several times in person, and a number of times via Zoom. We also actually managed to have 2 face-to-face meetings, despite COVID, and we had some nice social time as well. So there was a lot of theoretical discussion, as well as planning of work. Over and over, Stefan guided us through pretty intricate statistical designs, and I hope nobody asks me questions about these because I'm not the statistician in the group. Janet, who's here, helped us to see the value of participatory research and qualitative research. And I went on and on about sex and gender, as you can tell I would, and about intersectionality. And Ricardo integrated all our ideas and findings into a coherent whole. So what did we actually do or find? And I'll talk about this in terms of capacity building and research findings. So first, capacity building. We developed a data navigator where we mounted the data that we had analyzed. We used a number of large data sets like SHARE, the longitudinal versions of SHARE, and some Canadian data sets. And we mounted this information on a website in a way that would enable people to kind of dig down if they wanted to know, well, what was the situation in Spain? They could look at this data. And we also held a sort of a launch of the data navigator that about 100 people attended. I was quite astonished, virtually. We also held 2 PhD workshops on intersectionality. They were to have been held in Canada and in Sweden, but of course they ended up virtual. And so this is a screenshot of the Canadian one that I think about 38 or 39 people attended, and the Swedish one was smaller. And an outgrowth of those PhD workshops was an intersectionality journal club that went on for about 2 years, once a month, where a small group of people took part, but we reviewed key papers that used intersectional methods and really thought fairly deeply about intersectionality. And there was a ripple effect of involving more and more students and also your early career personnel, some of whom have gone on to become faculty members and to develop these concepts further. One has gone on to work at the WHO, and so there's been this spreading out of ideas. I think we gave 8 conference presentations. Nobody's quite sure exactly how many we've given, and there are a few more to come still. And I said that we had the 3 sounding board meetings that forged connections with policymakers, and the sounding board helped guide us and enable us to translate knowledge into action. We have 11 papers that either are published in press or underway. This is the list. Yeah, these are the ones that have been published. And there's, I think, another one just accepted. So that's the sort of capacity building. I hit a glass of water here, just a minute. As far as actual research findings go, so we were looking at health, care, and what I call gender methods. And these are the questions that were behind the research on health. And I'm not going to read them, but I'll just go through some of the findings. So for the first one, are there cohort, just a minute. Yeah, are there cohort differences in, oh, sorry, I'm out of line here. Here we go. So for the first question, we reviewed and reanalyzed data, and we found, and we wanted to do a systematic review, but there weren't enough papers to really call it a systematic review. But by doing a meta-analysis of the information, we did sort of come to some, I think, reasonable conclusions. We found that women continue to report more impairments or physical impairments than do men, that these inequalities could partly be attributed to male socioeconomic advantage, but not completely. And the magnitude of these sex differences varied greatly across the studies that were included, and they persisted across age cohorts. So we did multi-level analyses, and the multi-level was an age cohort. You were born between 1920 and 1930, for example. And even with younger populations, this female disadvantage persisted. We're now doing a very similar analysis of gender and mortality across cohorts and countries. Then Then we did a qualitative study where we gathered new data, and we wanted to augment quantitative findings. So we asked older adults, there were 30 men and 30 women in Sweden, Canada, and Austria, so total of 60, 20 in each country. We asked them what aging well meant to them, and responses were pretty deep and thoughtful and quite gendered. And all the respondents were over age 65 or 65 and older. And I can't really do justice to the findings in the time that I have, but I'll just say that everyone thought that women aged better than men and more easily than men. And women in general were focused more on social conditions of their lives and men on resources as being central to their well-being. So then we come to care. And the first question we asked was, how do marital status and living arrangements impact formal and informal care use amongst older adults? And we wanted to imagine social circumstances beyond those that are generally studied, like socioeconomic status or age, and that might shape health or care needs. So we hypothesized that care needs that often appear to be linked to sex might actually arise from changes in marital status, so changes like widowhood and bereavement, or in living arrangement that would be associated with those same changes. And so using share data, we found just that widowhood is associated with higher care use for all, that's men and women, but less so for men, suggesting that they may be more vulnerable to unmet needs at this key transition point in life. And then we asked, do gender differences in caregiving change with age and changing attitudes over time? So again, using longitudinal data from SHARE, we found that gender differences in caregiving persist among younger age cohorts. So again, this is this multi-level analysis with age cohort as the cluster. Care provision outside of one's household is decreasing among younger cohorts of men, but not women. And despite greater gender equality overall, men are providing less care for all but their spouse. So among younger cohorts, caregiving within the household has increased for women and men, but differently depending on location. Gender care gaps are widening in continental Europe, remaining constant in Southern Europe, and narrowing in Nordic countries. So you might think of those divisions by location as indicative of gender equality in general or attitudes in general. I don't think we went as far as to state that because that didn't arise from the research itself, but it's implicit in there. So in other words, the gender gap is not closing when it comes to caregiving, especially for care outside the home. And men are not taking up more caregiving, and women continue to shoulder this second shift. Now comes the part that I can speak to best. So this is about best methods for integrating gender into research. And so we asked, how are intersections of sex and social context studied in health research? And first we did a systematic review of this question that initially uncovered more than 9,000 papers. I was a bit daunted, but we went through them. We found a gap both in the sort of analytic potential of most methods used, but more so in theorizing that social circumstances might lead to heterogeneity within the categories of men or women, and that these underlie gendered effects on older adults' health. So in other words, intersectionality was not being considered by the researchers. And so we decided we should consider it. And then we did the next study, which was to apply one of the intersectional methods to look at care receiving. And so we used decision tree analysis, and we explored formal and informal care received by Canadians. And our surprise finding was that with this intersectional approach, living situation rather than sex per se seemed to explain gender differences that others had reported. So without doing an intersectional analysis, it would appear that the differences were about men and women, but when we did the intersectional analysis, that disappeared and it was about living situation. And finally, then we asked, do gender differences in interpretation of questions underlie and bias self-reported survey data? So here we used all these surveys and we sort of trusted the data, and then we thought, do women and men answer questions, do they attribute the same meaning to the questions before they answer them? And so we specifically looked at self-reported health, and we wanted to consider whether there were gender differences in how this question was approached. And if this were the case, then it might explain the paradox of women's poor self-rated health but greater longevity if they were not answering the same question when they rated their own health. So we surveyed 950 adults, mostly in Canada, but not entirely in Canada. This was an online survey. And we found that life circumstances considered actually did not vary greatly by sex. But women did rate their health poorer than did men. And so it would seem that women's lived realities were more dire than men's. And universally, women have poor self-rated health than men. So our conclusion about methods was there's no single best research design or analytic method to account for gender. Whichever method is used, it's essential to study intersections between sex and social circumstances to determine whether outcomes whose frequency appears to vary by sex are in fact a function of social circumstances, in other words, of gender. We've developed an approach to sex and gender research that sex is the individual trait, while gender is the intersection of that trait with social circumstances. And together, sex and social characteristics produce marginalization, but they also produce power and opportunities. And we think we've moved beyond the assumption that being a woman means being oppressed. There's a truth to this, but there are also associated strengths. And if we can find them, then we can build on them rather than just getting lost in a narrative of oppression. So what's the impact of our findings? We've done what we set out to, I'm going to skip ahead a bit. This is what we set out to do, and we've done what we set out to do. You can read that. We've considered that data don't lie, but they can hide the truth. And we've looked at how to better study sex and gender in quantitative research. We've documented how gender gaps in life expectancy, health, and care have changed over time or not changed, and over place and by decade of birth cohorts. But we can't explain those changes. We've engaged with policymakers, partly via our sounding board, so that our findings will translate into policy. Sorry. But there's still stuff to do. This is some of what we think remains to be done. And thank you.